On December 4th, 2024, Brian Thompson, the chief executive of United Healthcare, was shot and killed outside a hotel in Manhattan. He was there for an investor conference. The response from the public was unlike anything I have seen before in relation to a corporate killing. Across social media, thousands of people expressed not grief, but rage, not at the shooter, but at the insurance company Thompson had led. People shared stories of denied claims, of appeals rejected, of family members who had died after treatments were refused. The story of an algorithm called NHPredict, which United Healthcare had been using to automate decisions about who gets care, was suddenly everywhere. I'm not going to dwell on the murder itself, but I want to use that moment as a signal, because it revealed something that had been building for years in a system most people had no visibility into. A system where AI was already making consequential decisions about people's lives at an enormous scale, with almost no governance and almost no accountability. That is what this episode is about. Welcome back to The Cascade. I am Omid Razbani, Associate Professor of Systems Engineering. Over the previous 4 episodes, we looked at data center infrastructure, a catastrophic European blackout, Norway's electric vehicle transition, and the hidden supply chain beneath the green transition. Today, I want to look at something closer to home, something that does not involve power grids or copper mines, but that is equally complex, equally consequential, and in some ways more difficult to see clearly. AI in healthcare. Not in the future, now. Let me start with an idea I find genuinely useful for framing this episode. Healthcare, at its core, is a self-correcting system. You experience a symptom. That symptom signals something wrong. A clinician identifies what is wrong. Treatment is applied. The body responds. The clinician adjusts. New information comes in. The treatment is refined. The whole architecture of medicine, from the clinical encounter to the hospital to the public health system, is built around this feedback structure. Information flows in. Decisions are made. The consequence of those decisions flow back as a new information, and the system learns and adjusts. Now, what happens when you introduce automation into that loop? That is the central question of this episode, and the answer is not simple, because AI in healthcare has already produced genuine benefits, but it has also produced failures that the existing governance system were not designed to catch. And some of its failures are self-concealing in a way that is almost uniquely dangerous in a system where the stakes are human life. Let me give you some historical background, because I think it matters for understanding where we are now. The first use of AI in medical imaging dates back to 1992, when computer-aided detection was used to find microcalcification in mammography. It was a narrow, specific tool, not a replacement for the radiologists, but a second pair of eyes. It stayed that way for more than 2 decades. And then, in the mid-2010s, something changed. Deep learning, a specific approach to machine learning using neural networks with many layers, suddenly began producing results in image recognition that surprised even its own developers. The moment that crystallized the debate was 2016. Geoffrey Hinton, one of the founders of deep learning and later a Nobel Prize winner, made a prediction that became famous. He said, "If you work as a radiologist, you are like Wile E. Coyote in the cartoon. You are already over the edge of the cliff. but you haven't yet looked down. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists. This was not a fringe opinion. Hinton was one of the most respected figures in the field. Medical schools were genuinely discussing whether to stop training radiologists. In 2017, a Stanford team published a landmark study in Nature showing that a deep learning algorithm could classify skin cancer from images with accuracy comparable to board-certified dermatologists. It seemed like confirmation. By 2019, one study showed that AI outperformed 136 of 157 dermatologists in melanoma detection. But then something interesting happened. The AI hype cycle in radiology began to quiet. The dramatic results from controlled studies failed to pan out at the same level in real-world clinical settings. By 2024, 8 years after Hinton's prediction, the field was not facing replacement by algorithms. It was facing the largest radiologist shortage in history. Imaging at some centers was backlogged for months. This is an important lesson for the rest of this episode. AI, as a tool that supports a human expert, works and produces real benefits. AI as a replacement for human judgment is where the serious problems begin. Today, AI is achieving up to 94% segmentation accuracy and 95% nodule detection sensitivity in radiology. The studies show that human-AI collaboration reduces scan time and reporting time while maintaining diagnostic accuracy above human performance alone. These are genuine improvements. They are saving time, catching things that would have been missed, and helping manage growing workloads. But radiology is the mature application, the easy case. The images are structured data. The task is specific. The radiologists retain final authority, and even here, the promise was initially oversold. Now AI is moving into harder territory, into triage, into clinical decision support, into insurance authorization, into the decisions that determine who gets care and who does not. And in these domains, the failure modes are different and more dangerous. I want to explain a specific technical risk that I think is not widely understood outside the research community. It was described in a paper published in Proceedings of Machine Learning Research in 2020 by George Adam and colleagues at the University of Toronto and the Vector Institute. The paper is about something that authors call the feedback loop problem in healthcare AI, and I think it is one of the most important and unsettling findings in this field. Here is the core idea. When a machine learning model is deployed in a clinical setting and clinicians begin following its recommendations, those recommendations change what actually happens to patients. And those changed outcomes become the training data for the next version of the model. The model is then learning from a reality that it partly created. Let me make this concrete with the example from the paper. Suppose a model is predicting which patients in an intensive care unit are likely to die. The model assigns a high probability of death to a particular patient. The clinician, trusting the model, decides to shift that patient to palliative care, comfort treatment rather than active treatment. The patient dies. That death is now recorded in the data as a confirmed prediction. The model is updated. It becomes more confident in its prediction of death for similar patients. The false positive rate, the rate at which the model predicts death for patients who, with treatment, would have survived, begins to grow, and with each update, it grows further. The authors showed this empirically on real ICU data covering more than 2 decades. When clinicians fully trust the model, the false positive rate grows uncontrollably with each update. The model degrades, but it degrades in a way that it is very difficult to detect using standard accuracy metrics. From the outside, looking at the standard measures, the model appears to be performing well. The problem is hidden in the very structure of the feedback loop. This is the model corrupting its own training data, not through malice, not through negligence, through the normal operation of a deployed AI system in a complex adaptive environment. Now think about what this means for the self-correcting structure of healthcare I described at the beginning. Medicine works because information flows back, because what happens to patients after treatment tells clinicians something true about whether the treatment was right. The feedback loop is the mechanism of learning. But when the AI is reshaping what happens to patients and those reshaped outcomes flow back as training data, the feedback loop is no longer telling the truth. It is telling the model a story that model partly wrote, and the model is learning from its own story. This is a hidden corruption of the very mechanism that was supposed to keep the system safe. Now I want to move from the research lab to the real world, because the feedback loop problem I just described is not purely theoretical. Versions of it are already playing out in systems that are making life and death decisions about millions of people. The most documented case is the United Healthcare story. United Health Group is the largest health insurance company in the United States. In 2020, it acquired a company called Navi Health for over $1 billion. Navi Health had developed an AI tool called NHPredict, designed to determine whether Medicare patients should receive post-acute care, rehabilitation in a skilled nursing facility after a hospital stay, for example. The way the tool was supposed to work, it would analyze patient data and predict how long a patient would need post-acute care. The prediction would guide the coverage decision. The way it actually worked was United Healthcare used the tool to deny care. Internal documents revealed in a StatNews investigation showed that managers set a goal for clinical employees to keep patients' rehabilitation stay within 1% of days projected by the algorithm. When the algorithm said a patient needed 14 days of rehabilitation, staying for 20 days would trigger a review. The algorithm's prediction was in practice a ceiling. The result was that United Healthcare's denial rate for post-hospital care more than doubled between 2020 and 2022 after implementing the algorithm. Patients who needed care were denied it. Some of them got worse. A class action lawsuit filed in 2023 by the families of deceased patients alleged that the tool had a 90% error rate, meaning 9 out of 10 denials that were formally appealed were ultimately reversed. The policy said coverage decisions would be made by clinical staff or physicians. In practice, they were being made by an algorithm. In March 2026, a federal judge ordered United Health to hand over broad discovery documents about the implementation and use of the tool. The case is proceeding. And in the meantime, United Health, Humana, and Cigna are all continuing to invest in AI for claims automation even as lawsuits proceeds. The commercial pressure to automate is not being slowed by the legal challenge. The system is continuing to move in the same direction. The industry frames this as an efficiency problem. The volume of claims is too large for human reviewers to handle at a reasonable cost. But I want to be direct about what that argument obscures. These are among the most profitable companies in the American economy. The decision to automate was not made because human reviewers were unavailable. It was made because automation is cheaper and, as the lawsuit evidence suggests, because it denies more claims, which increases revenue. The efficiency argument is a justification, not an explanation. Let me shift from insurance to clinical care, because the failure modes are equally concerning and even less visible. In January 2026, a company launched an AI health tool designed to be, in their words, a patient's first stop for medical advice. By February 2026, Mount Sinai researchers had conducted the first independent safety evaluation of the tool and published it in Nature Medicine. What they found was that the tool under-triaged 52% of genuine medical emergencies. People describing symptoms of respiratory failures, diabetic ketoacidosis, and other life-threatening conditions were not being directed to emergency care. The tool also had serious failures in its suicide crisis safeguards. Isaac Cohen, chair of biomedical informatics at Harvard Medical School, commented, LLMs have become patients' first stop for medical advice, but in 2026, they are least safe at the clinical extremes, where judgments separates missed emergencies from needless alarm. When millions of people are using an AI system to decide whether they need emergency care, the stakes are extraordinarily high. This is not an isolated finding. ECRI, the organization that produces an annual patient safety report for the healthcare industry, ranked AI diagnostic risks as its number one concern for 2026. They documented that some machine learning models failed to recognize 66% of critical or deteriorating health conditions in simulated cases. And a peer-reviewed systematic review in the Lancet Regional Health examined studies of AI-based decision-making systems used by healthcare professionals and found that the impact on patient-relevant outcomes remains uncertain, with significant risk of bias in existing studies. Now put these two threads together. The insurance AI denying care that patients need, the clinical AI missing emergencies that patients have, both operating at the scale, both producing failures that individual patients experience acutely but that are nearly invisible at the system level, both moving faster than the governance frameworks designed to catch them. This is what the deployment of AI into a tightly coupled, high-stakes system looks like when it is moving ahead of our understanding of its failure modes. Now I want to raise the accountability question, because I think it is genuinely unresolved in a way that matters. Johns Hopkins Carey Business School published an analysis in May 2026 that articulates the problem precisely. Clinicians are now in a double bind. They are expected to rely on an AI tools that may not fully understand. They are blamed when AI leads them to wrong decisions. And this is the part I find most striking. They could also be held accountable in the future for failing to use AI at all if AI becomes the standard of care. Think about what that means practically. A clinician who follows an AI recommendations that turns out to be wrong can be sued for negligence. A clinician who ignores an AI recommendation and it turns out to be wrong can also be sued for negligence. The AI tool itself cannot be sued. Its developers have terms of service that limit liability, and nobody has yet established a clear legal framework for shared responsibility between the clinician, the hospital, and the AI developer when things go wrong. Under current US malpractice law, liability rests on the standard of the reasonable physician under similar circumstances. Whether AI was used or not, courts judge the physician's conduct. The AI is not a party to the lawsuit. The feedback loop of accountability, which is supposed to create pressure to improve, is broken. The entity making the decision is not the entity bearing the consequences. This is a governance failure, not an accident, not a conspiracy, but a governance failure in the specific systems engineering sense. The feedback mechanisms that are supposed to keep the system safe are not connected to the components that are producing the risk. And now I want to add a dimension of this story that I think is almost completely absent from the public debate, because the double bind I just described does not only have legal consequences, it has human ones. AI was introduced into clinical settings partly to reduce physicians' workload. Burnout among doctors was already at alarming levels before any of these began, defined by emotional exhaustion, reduced sense of efficacy, and a feeling of disconnection from the work. The promise was that AI would take routine tasks off the physician's desk, freeing time for the human parts of medicine that machine cannot do. What is actually happening in many settings is the opposite. The Johns Hopkins analysis introduces a concept I find very precise: the calibration burden. This is the ongoing mental calculation that every clinician must now perform when working alongside an AI system. Should I trust this recommendation? Does this particular case fall within the range of cases the model was trained on? Is the confidence score meaningful here? When should I override it? That calculation does not happen once. It happens with every patient, every recommendation, every interaction with the system. It is the second job running in parallel with the first. And unlike clinical judgment, which deepens with experience and becomes more intuitive over time, the calibration burden does not lighten. It accumulates, because the AI system changes as it is updated, which means the clinician must continually recalibrate their trust in it. There is another effect worth naming. Medicine has always been a collaborative profession. When a clinician is uncertain, they consult a colleague. They ask for a second opinion. They talk through the case. That collaboration is not just a safety mechanism. It is how clinical judgment is developed and maintained over careers. It is how the social fabric of healthcare is built and sustained. When the algorithm provides a recommendation, there is less incentive to seek that second human opinion. The social interaction that would have happened does not happen. Fewer conversations, fewer collaborative moments. The clinician faces the complexity of an AI-assisted decision largely alone, and often cannot even explain the AI's reasoning clearly enough to discuss it with a colleague. The result is a kind of professional isolation that has real consequences for both physician well-being and patient safety. The clinician who feels supported and connected makes better decisions than the clinician who is stressed, isolated, and carrying an invisible cognitive burden that nobody else fully understands. I want to be clear about what this means for the governance argument. The EU AI Act requires human oversight of high-risk AI systems. That requirement is right, but human oversight is not free. It has a cost measured in cognitive load, in time, in the mental and emotional resources of the people providing that oversight. If we design AI systems that nominally have a human in the loop, but where that human is overwhelmed, isolated, and unable to genuinely evaluate the AI's output, then the human oversight is performative rather than real. Genuine human oversight requires that clinicians have the time, the training, the tools, and the institutional support to actually exercise that oversight meaningfully. That is a very different design challenge from simply requiring that a physician sign off on an algorithmic recommendation. Now let me add the regularity dimension, because something important is happening right now in Europe. The EU AI Act, which entered into force in August 2024, is reaching its most important compliance deadline this coming August. The Act classifies AI systems used for diagnosis, clinical decision support, treatment recommendations, patient triage, and patient monitoring as high risk. From August 2026, these systems must meet strict requirements: conformity assessment, technical documentation, human oversight mechanisms, and transparency obligations. This is significant. It is the first major regulatory framework that explicitly addresses AI in healthcare as high risk and requires human oversight to be designed into the system, not added afterwards. But here's the problem. A study of European healthcare facilities found that only 26% of hospital representatives feel ready for the obligations introduced by the Act. The compliance burden is substantial. Many smaller healthcare providers do not yet understand what is required of them, and the regulatory timeline is already being adjusted. Medical devices with embedded AI have received an extension to August 2027 or 2028 under the Digital Omnibus proposals. So the government response exists in principle, it is coming in practice, but the AI is already deployed at the scale, making consequential decisions right now. Now let me bring this to Norway, because the Norwegian situation is both reassuring and worth watching carefully. Norway has one of the most digitally mature healthcare systems in the world. The national platform Helse Norge gives citizens access to their medical records, allows them to book appointments, and manages electronic prescriptions through a system called eResept. The Stjernejournal gives clinicians access to essential patient information across providers. The Norwegian Health Network provides the secure digital infrastructure that connects the whole system. This is genuinely impressive, and it creates a foundation on which AI can be deployed much more effectively than in countries with fragmented or paper-based records. Helsedirektoratet, Norway's Directorate of Health, published a report in late 2025 assessing the development of a public AI service for health-related questions on the Helse Norge platform. The framing is careful and responsible. Norway has high-quality health data, strong professional communities, a high level of digital maturity, and a society built on trust. Together, these provide excellent conditions for developing and implementing AI solutions in health and care services. I agree with that assessment, but I want to add something. Trust is a resource. It takes a long time to build and can be damaged very quickly. The cases I have described in this episode, the insurance algorithm with a 90% error rate, the triage AI missing half of all genuine emergencies, the feedback loop that corrupts its own training data, these are cases where AI was deployed into healthcare systems without adequate governance. The patients who were harmed did not stop trusting their healthcare system in the abstract. They trusted it, and it failed them, specifically because of an AI decision they could not see, could not appeal effectively, and for which nobody was clearly accountable. Norway has a significant advantage in the strength of its institutional trust and the quality of its public healthcare infrastructure. That advantage should be used to design AI deployment carefully, with genuine human oversight, rather than to accelerate deployment on the assumption that strong institutions will catch the problems. Norway will implement the EU AI Act requirements alongside the EU. The August 2026 deadline for high-risk AI applies. That means that any AI system in Norwegian healthcare used for diagnosis, triage, or clinical decision support must now meet the conformity and oversight requirements of the Act. That is the right framework. The question is whether the implementation will be serious or performative. Let me come back to where I started. The United Healthcare case is the most dramatic and visible example of what happens when AI is inserted into a healthcare system without adequate governance. But it is not the only one, and it is not even the most technically interesting one. The feedback loop paper I described, where an algorithm degrades because it is learning from a reality it partly created, is the most disturbing example, because it shows that the problem is not just bad actors deploying AI carelessly. It is that AI in a complex adaptive system like healthcare can produce failure modes that are structurally hidden, that look like correct behavior from the outside, that require sophisticated analysis to detect, and that grow worse, not better, the more the system is used. This is the challenge. Medicine is a self-correcting system. Its power comes from feedback, but AI can corrupt the feedback loop in ways that are not immediately visible, and by the time the corruption is visible, the harm has already been distributed across millions of patients. Yuval Noah Harari, speaking about AI in healthcare, made an observation I keep coming back to. He compared AI deployment in healthcare to the social media experiment. Social media, he said, was the first system populated by both human persons and AI agents. It doesn't look very good, he said. This is likely to happen in more and more fields. I think that framing is right, but incomplete. Social media's failures, while serious, are mostly reversible. You can stop using a platform. You can correct a piece of misinformation. Healthcare decisions are often not reversible. A patient denied post-acute care who deteriorates. An emergency missed by a triage algorithm. A palliative decision made for a patient whose death then trains the next version of the model. Harari also warned against two reactions: the dystopian, shut it all down, and the utopian, release it and let the market self-correct. He said the job is to think deeply and manage the transition responsibly. I agree. And from a systems perspective, managing the transition responsibly means three specific things. First, human oversight must be designed into AI systems from the beginning, not added later. The EU AI Act is right about this. Systems that make decisions about patient care must have a human in the loop who understands the system's limitation and has the ability to override it. Second, the feedback loop must be monitored for corruption. The finding from the Adam et al. Paper is that standard accuracy metrics do not detect the feedback loop problem. Healthcare AI systems need monitoring frameworks specifically designed to detect the kind of distributional shift that occurs when the model's output are changing the reality it is trying to measure. Third, accountability must be assigned before harm occurs, not after. The current situation, where no one is clearly responsible when an AI healthcare decision causes harm, is not a stable state. It will be resolved either by deliberate governance design or by a series of catastrophic cases that force the issue. The EU AI Act is a step in the right direction, but implementation in Norway and across Europe will determine whether it is a genuine governance tool or a compliance exercise. The cascade in healthcare AI has not happened yet, but the conditions for one are being assembled. Fast deployment, inadequate oversight, corrupted feedback loops, and a governance framework that is racing to catch up with technology that is already in use. I am Umid Rezvani. Thank you for listening to The Cascade. Next episode, we pick a new story and find the system underneath.